trying to review some of these cases, give you some images to look at and see what you think. You know, with ultrasound, it seems like you see one, do one, and the more you see, the easier it is to recognize it next time. A lot of it's pattern recognition. And then we also didn't have enough space to get a lot of the skeletal abnormalities in there, so we're going to spend half of this with going over an overview of skeletal dysplasias, so you have that with you also. Birth defects. When we look at birth defects, about 5% of them are going to have chromosome abnormalities. 15 to 20% are going to be single gene disorders. 10% are from environmental exposures, but look at 60 to 70% are multifactorial, polygenic, or of an unknown cause. Most of your birth defects we have no cause for. Chromosome abnormalities, again, greater than 90% do not survive to term, so you end up with a lot of your first trimester losses have chromosome abnormalities. The more organs that are involved, the greater the chance that they're going to end up with a third trimester loss or not survive beyond that first year of life. They have reduced longevity, and they have a high association with mental retardation. Structural abnormalities, on the other hand, only occur at about 2 to 3% of your live births. So some of these are going to die in utero, but 2 to 3% of live births. 25% are cardiac in origin. 22 are muscular skeletal in origin. And there's 20% involve the GU system, and 10% are CNS in origin. So some of the ultrasound facts. If anomaly is encountered, the first thing you want to do is just kind of take a breath, reset your image, adjust the depth, the magnification, your focal zone, the gain. Make sure you switch to the higher frequency transducer if you have one available. Try to optimize your frame rate. View the abnormality in multiple planes, but before anything else, finish all of your biometry. Because what happens is you get so stuck on looking at the abnormality, you forget to get the basic things that you need. So do your fluids, do all the anatomy, look at everything else, then go back. So if you see an anomaly, don't stop and just focus on that. Get everything else, and then go back. Because once you start focusing on one thing, then parents go, well, why do you keep looking at that? What's going on? Is it abnormal? And the questions start coming. So try to get everything else done before you get sidetracked, okay? So don't panic, complete your survey, get your measurements, any additional views that you might need, then go back to the area of the abnormality, do some clips through there if you're able to store clips, and then search for other abnormalities. The more abnormalities that you see, the greater the risk for chromosome abnormalities or some type of a genetic syndrome. You also want to make sure you're assessing the fluid, fetal movement and tone, not just the anatomy, but is that baby moving well? Is it just floating in there in the fluid, or is it moving around well? Add the Dopplers if the baby's measuring small. Assess the maternal pelvic structures, and then if nothing else, go ahead and get another sonographer or your doc to come in with you. Get a second pair of eyes. Sometimes that's what you need. So we're going to go through these case by case. I'm going to present the history because that's important. Then we'll go over some images and some video clips. We're going to go over differentials, and then we'll go through what we found out it was once the baby delivered. So this first one, 19-year-old, her second pregnancy, she's had one previous miscarriage. She comes in with an MSAFP of 4.73 MOMs and history of first trimester spotting. So does everybody know what the cutoff is for the maternal serum AFP? Some labs it's 2.0, some it's 2.5. So know what the cutoff is in your lab. So this is 4.73, so that's pretty high. These are images both coronally and sagittally. Then looking at the spine. So spine up, and then when the baby rolled the other way, spine down. So elevated MSAFP, 4.73 MOMs. Differential would be acrania, anencephaly, a cervical bifida, or encephalocele. What do you think? So it's your anencephaly, that's that typical frog eye appearance. So most of these, when you scan them early on, it's actually in an acrania. There's no calvarium there. But as the neural elements, the brain is exposed to the amniotic fluid, the little particles you see floating around in the fluid is what's left of the brain. It's floating around in there. So by the time that they are delivered, it is an anencephalic. Our second case is a 29-year-old. She's had a previous 20-week loss. She has a history of having an HSG, a hysterosalpingogram, in the early pregnancy, before she knew she was pregnant. So they must not have done her pregnancy test before they did this. She has no significant family history, and she has a history of a negative quad screen. So it's looking at the cross-section of the uterus. The placenta is anterior, part of the baby's head here, and I'm looking over at this left uterine wall, and it looks like cord is coming over here. So if we're seeing something in 2D and you're worried about an abnormal cord insert, what do? Let's put color on it. So again, making sure that yes, that is cord insertion there and not just a loop of the cord sitting over there. So, and that was a different baby, but again, same principle. So baby's laying here, placenta again, the anterior wall. So with colors where I can see that the cord insertion is actually up here in the fundus, then these vessels are traveling over to the placenta. So filamentous cord insert, uterine synechia, uterine septum, or a bilobed placenta. What do you think? Filamentous cord insert, correct. But again, unless you start looking for those cord insertions in the placenta, you are not going to pick this up. Okay, case 3, looking at a 23-year-old. She was referred to us for a cyst in the left chest, no significant family history, and a negative quad screen. So looking at a sagittal view here, we're looking at the right diaphragm, looking at the liver and up into the right chest. And then looking over at the left chest, we see heart here, spine posteriorly. On the sagittal view, we see this cystic structure. So we'll describe what we're seeing that seems to be posterior to the heart. So what would be our differentials on these? Right side, the diaphragm looks good. And the other thing I should see, if I see diaphragm here, should I see stomach below the diaphragm? So, is it a CCAM, a congenital cystic adenomatoid malformation of the chest, a diaphragmatic hernia, a heart defect, or chest teratoma? Correct. So location, location, location. Where is the anechoic structure? Where is the stomach? Is it above or below the diaphragm? So case 4 was a history of a 28-year-old that was obese. She declined her genetic screening. She has no significant family history, and she was referred at 26 weeks for dilated lateral ventricles, cerebral ventricles. So you see a little obese, I mean, it's a difficult scan. We're measuring the lateral ventricle. Remember, it should be below 10. This is measuring 12.5 millimeters. But then looking down at the spine. So it's like a little coronal view of the spine. A little bit of the spine here. I'm trying to get you, this is where you have to make sure you get the spine separate from the uterine wall. So if you have to roll them or whatever you do so you can see the spine, you want to see amniotic fluid between the spine and the uterine wall, or you're going to miss this defect. So obesity and dilated lateral ventricles. Our differential that we have listed is hydrocephalus, encephalocele, acrania, or spina bifida. Spina bifida, correct. So, and a lot of times she was a very difficult study. Usually it's the head findings, though, that are going to tell you, look at my spine, look at my spine. So the ventriculomegaly, and then looking at the abnormal shape of the cerebellum and obliteration of the cisterna magna. Those are your clues. So usually the head findings are telling you that I have a spinal abnormality. Then you have to go and track it down as to where it is. So just be, do due diligence, make sure that you do roll the mom, try to get that baby to move away from the uterine wall. You need to be able to see amniotic fluid in between the uterine wall and the spine. Okay, case number 5 was a 38-year-old. So we have an AMA, no quad screen. They said they could not see the 4-chamber view well. So she's supposed to be 25 weeks, measuring 24 and 4, but let's look at these individually. So she's supposed to be 25 weeks. Well, the BPD is measuring 25 weeks. Head circumference is measuring 24 and 3. AC is measuring 24 and 3. Femur is measuring 23. Cerebellum is measuring 26. Humerus is measuring 23. Foot is measuring 25. So look at how both the humerus and the femur length are measuring smaller. Everything else is measuring within normal range for the assigned gestational age. Now we're looking at the heart. So looking at the posterior to anterior, left to right, cross section of the heart in that 4-chamber view, and then putting color on here because it looks like there might be some loss of integrity of that septum there. We look at the nasal bone. Remember, that's one of those things we can use throughout pregnancy because now she's over 21 weeks, she's 25 weeks. Let's go ahead and do the BPD nasal bone ratio. So she had a BPD of 6.2 centimeters, and then the nasal bone length was 5 millimeters. So you're going to take this in millimeters, divided by this in millimeters, and times it by 100 to get your ratio. So this BPD nasal bone ratio was 12.46. And what did we say was abnormal? Anything greater than 10. Remember, anything in the head, 10. Ventricles should be less than 10. Cisterna magna should be less than 10. BPD nasal bone ratio should be less than 10. Okay? So again, that's one of those people that, when they come for late registration or you're seeing them for the first time after 21 weeks, a lot of these other little genetic markers that we look for are no longer there or really don't count for much. They're very weak markers at this time. This BPD nasal bone ratio really, really does help. So we had the heart defect, and then we had the short arms and legs, and then the abnormal BPD nasal bone ratio. And you see how this tongue is sticking out here? Well, the majority of the time, this baby had this tongue hanging out. So she did proceed with amniocentesis, and this was a Down syndrome. Very good. But see how you go from one thing to the other. Oh, I see heart defect. And remember, 50% of Downs, but 80 to 90 of 18s and 13s all have heart defects. So that may be your first clue that this baby has something globally going on, is that there's a heart defect. Okay, case number 6. So a 25-year-old, abnormal triple screen. She had an elevated MSAFP and an HCG. So if 2 or 2.5 is our cutoff, this was 3.38 for the AFP and then 2.38 for the HCG. And then they thought they saw something on the placenta. So this is looking at the placenta's posterior. This is a transverse and a sagittal image of the placenta. So here's the placenta here. Here's a little bit of the myometrium, a little bit of fluid around there, and this is what we're seeing. Just looking at a different, now it's 28 weeks, so this was 24 weeks. This is 28 weeks. Now by this time, this baby is starting to leg off in growth. So what do you think this could be? Placental teratoma, placental lake, placental hemorrhage, placental infarct, or chorioangioma? What's the most common placental tumor that we see? Chorioangioma. And because they're highly vascular, they can actually shunt blood away from the baby. So then you end up with a growth delay and even sometimes decrease fluid around the baby. Because, the kidneys are making 80% of the fluid around the baby. So if there's not as much blood supply going to the baby's kidneys, one of the first effects you see is a decrease in the amount of fluid around the baby. So this was a chorioangioma. So case number 7. So 43 years old, so she's AMA, gravida 4, para 3003, declined serum screening. She's 34 weeks, 3 days by LMP and early ultrasound. She comes in for size less than dates, 2-vessel cord, and a suspected facial abnormality. So this is the first time we're seeing her is at 34 weeks, 3 days. Welcome to my world. So we're looking at a cross-section, looking at the placenta, and I'm trying to get cord inserted into the placenta. So what do you think about that cord? Look how straight it is. Shouldn't you have some coiling in there? And then we look into the insertion into, so I was looking at the placental cord insert and then looking at the umbilical arteries coming around the bladder. So I put on my color and I'm turning up my gain. She's 34 weeks, a little bit harder to see, but I'm only seeing one artery, so single umbilical artery. So now we have this straight cord. We still have normal fluid. I've got a single umbilical artery. This is my profile. So looking at top of the head, back of the head, a little bit of the chest, an arm here, and this is the chin tucked down to the chest. This is the area of the face, the upper jaw, and the nose. Let me look at everything else. Oh, I'm looking around. Now I'm seeing a thumb, 4 fingers, oh, and another one. So you've got, which kind of polydactyly do we have? Postaxial, it's on the pinky side. So postaxial polydactyly, that is the most common type. So if we look at the hands, then look at the other hand, and then we look at the feet. But this is that defect here in the upper jaw. So, but it's a combination of everything. So it's 43 facial abnormalities, growth delay, single umbilical artery. So I mean, they got the basic things, that it was growth delay, but they missed the single umbilical artery, and they missed the facial defect. So, but a combination of all of this, along with the age, what do you think? Cleft lip palate, trisomy 21, 18, 13, and cephalocele. So polydactyly, facial abnormality, growth delay, single umbilical artery. It's trisomy 13. So again, looking from one thing, you see one thing, go to the next, to make sure you check those hands, the posturing of the hands, posturing of the feet. If you see one defect, look for more, especially when it's those midline defects. Okay, case number 8. So 38-year-old, no quad screen, no family history, CPC's on an 18-week scan. So she's supposed to be 19 weeks, 6 days. So the BPD is measuring 20, the head circumference 20, the AC 18 and 3, femur length 18 and 6, cerebellum 25, and then the humerus 18 weeks, 6 days, and then the foot 19 weeks, 5 days. So we're looking through those. This is looking at a cross section of the abdomen. So this is my ventral wall. So unless that's a funky scrotum or something, that shouldn't be there. So let's put on some color. Single umbilical artery. Looking at the kidney. Looking at the hand. And when this baby moved, the hand stayed like that. So AMA, but AMA with CPCs and looking at the small omphalocele, so that was the omphalocele. So small omphalocele has a higher risk of aneuploidy. You start seeing that, really pay attention to the hands, either looking for polydactyly for your trisomy 13, abnormal posturing for your trisomy 18. But chorioplexus cysts, especially large chorioplexus cysts, even if they regress later on, those have a higher association with trisomy 18. Okay, case number 9. So a 39-year-old, so another AMA, quad screen gave her a Down's risk of 3,384, suspected hydrocephaly. She's now at, of course, 36 weeks, 5 days. And I'm supposed to do a level 2. All right, so left side down. So I'm looking at that ventricle going, oh, okay. And it'd been scanned a couple times. They've been following it up. Now, is this your typical hydrocephalus? Should the cerebrum be pulled away from the skull like that? So everything else on the baby looked okay. So fluid in the brain, as you know, the ventriculomegaly is why she was referred. So hydrocephalus, cerebral hemorrhage, schizencephaly, communicating hydrocephalus. So it's actually a clefting in the brain that's communicating with the ventricle. So when you see the dilated ventricles, make sure, even though it's a pain in the butt to try to get the ventricle that's closest to the skull, that's closest to the transducer, angle around, you need to be able to see both of those ventricles. Don't just go by one. They just, they kept, that one side was down and they never saw this other abnormality. So totally different prognosis for this child. So make sure that you're looking for the side that's closest to the transducer also. Roll the patient. If you've got a bed that goes Trendelenburg, put them in Trendelenburg. Let gravity pull that baby's head out of the pelvis so you can try to get it. Roll them around. You have to be able to see that both sides of the cerebrum. All right, case number 10. So a 23-year-old, gravida 2, para 1, She's at 17 weeks. They noticed at 17 weeks, there's a 2-week leg in growth. 2 weeks already at 17 weeks. Facial abnormality, they thought there was something, the face just didn't look right to them. A suspected gastroschisis, no other significant family history, no history of bleeding or leaking of fluid. And our images are looking at the head, top of the head, a little bit of the area of the palate and the mandible, looking back to the spine, to the little tush. And this is what they were calling the gastroschisis. The cord did insert into the defect. It did not insert normally into the abdominal wall. Looking at the hands, postaxial polydactyly, looking at that head shape. Cross-section of the abdomen. So this to me looks more like an omphalocele than a gastroschisis. Then looking at a transverse of the heart defect, and 2 large echogenic foci. So we have a combination of this facial and abdominal defects. So this is our differential 21, 18, 13 triploidy Turners, but because of the early growth restriction, we thought it was triploidy, and that's what it ended up being. Okay, case number 11, 34 years old, gravid 3, para 2002, a negative triple screen, no significant family history. She's had a previous normal 20-week scan. Now at 26 weeks, she's being sent in for a growth study. And they had a facial anomaly that was identified when we did the growth study. So she had the normal 20-week study. Then it was being referred in after the growth study. So let's look at a little profile. Little nose, upper lip, lower lip. Now this is kind of like a semi-coronal through the face. It took forever for this child to turn. But looking at upper lip, lower lip, and then this little thing. So unless they're sending pacifiers in now at conception, that shouldn't be there. So as this baby, it took forever, like 20 minutes to wait for this baby to actually start sucking. You can see, and it looks like the baby's sucking on a big old pacifier. But the fluid's still normal. So anytime you're looking at a facial abnormality, one of the things you worry about is that it's blocking the baby's ability to swallow enough fluid, so they end up with polyhydramnios. Did not have polyhydramnios, because when we look at these, we have to figure out, is this a baby that's going to need an exit procedure or not? Are we going to have a problem establishing an airway once this child gets here? So epignathus was one of the differentials, the facial teratoma, a congenital epulis, and then the lipoma. So that's what it was. It's actually that little stalk you saw is coming down into the teeth buds. So it's this soft tissue mass that's on a stalk, and then it's like a big old pacifier that the baby was sucking on. Very rare. I've seen 2 in 36 years. It's very rare. All right, so case number 12 was a 31-year-old, had a fetal abdominal mass on outside scan, a negative quad screen, and no significant family history. So we're scanning coronally and then transversely. We identified the kidney, and we see that we're describing this mass. Now we see this pretty well circumscribed structure that has an echogenicity greater than that of the kidney, just at the superior aspect of the kidney. So then posterior to anterior, left to right, this is the transverse of that. So the coronal and the transverse. So let's put some color on it. Let's see what kind of blood supply it has. It's below the diaphragm. So what's our differential? So extralobar pulmonary sequestration, nephroma, or neuroblastoma. So we put the color on there, and I didn't see anything coming directly off the aorta. So I don't think it's an extralobar pulmonary sequestration. Nephromas are not that common, but because of the size and the location of this, most common thing that it would be is going to be the neuroblastoma. So just remember, with the neuroblastoma, they're not always going to look echogenic like this. Sometimes they can look cystic in appearance, and sometimes they can be complex. So they're not always going to look like this. All right, case 13. So 26-year-old, 20 weeks, 4 days, had a normal quad screen, normal family history, and short long bones on her outside scan. So you can see she's supposed to be 20 weeks, 4 days, but her BPD is measuring 23 weeks. Her head circumference is measuring 22 weeks. AC is measuring on target at 20 weeks, 6 days. Femur length is measuring 15 weeks, 4 days. Humerus is measuring 15 weeks, 3 days. And then the foot. How many people are doing the femur-foot ratio? Okay, so in your normal fetus, I mean, the femur and the foot should grow at the same rate from 14 weeks to 40 weeks. So you can actually measure the femur length divided by the foot length, and that should be normal if it's greater than 0.87. If it's less than 0.87, then it's abnormal. So that's one of the things, because a lot of times you're like, okay, is a femur short or is the baby big? What's going on? Is this truly a short femur? So this is one of the things that you can do, is look at the femur-foot ratio. So look, the foot is measuring 20 weeks, 2 days. So when we look at this femur-foot ratio, it's abnormal. So looking at the head, what do you think about that head shape? Look at that. Yeah, it's not a normal head shape. Now we're looking at from that coronal, looking from the chest down to the abdomen. So now you got, okay, so the abdomen was measuring on target, but look at the size of that chest. So this is like a bell-shaped appearance to the chest. And then looking at the long bones. So they're measuring almost 5 weeks behind. So if it's less than the first percentile, you have to evaluate them for skeletal dysplasia. When we're looking at the bones, so we're looking at the echogenicity and then looking at the shape and the echogenicity. What is the mineralization of that bone? So short, long bone. So what's our differential? So focal femoral hypoplasia, achondroplasia, thanatophoric dysplasia, achondrogenesis. Thanatophoric because of the head shape, the chest size, yeah, all those different things. I'm going to spend the rest of the time going over some of those skeletal dysplasias because they can be a little confusing. So we're going to just do an overview. I just want to thank Dr. Danilenko. She's one of the docs that I work with that does a lot with skeletal dysplasia. She's a whole community in the Minneapolis area that come directly to her just because of all of her evaluations over the year. So skeletal dysplasias, remember, the heterogeneous complex group of nearly 300 genetic disorders affecting the musculoskeletal system. So there's no way you're going to know them all. So we're going to talk about the more common ones. Only a minority are amenable to diagnosis by prenatal ultrasound. There's actually a skeletal registry that you can contact, and you'll send them your images, and they'll look at them and they'll try to help you decide what type of a skeletal abnormality it is. Prevalence is about 2.4 per 10,000 births. 23 will end up with stillbirth, 32% will die in the first week of life, and a lot of that is from the pulmonary hypoplasia, that small chest. So thanatophoric dysplasia accounts for about 29%, other about 19%, 15% for the achondroplasia, osteogenesis imperfecta about 14%, achondrogenesis 9%, the fixating thoracic dysplasia 6%, and the camptomelic dysplasia and the chondrodermal dysplasia right about 2%. So at least this is just giving you a nice little pie chart of, what's the chances if I see a skeletal or suspect a skeletal problem, what's the higher chance that it's going to be one of, the thanatophoric or the achondrogenesis or the osteogenesis imperfecta. So precise diagnosis is difficult by ultrasound alone. You usually have to get a geneticist involved. You can do some molecular or genetic testing. So you take some amniotic fluid and you can send it off for them to test. There's a whole list of skeletal dysplasias that they can test for now in the labs. So our job is to determine whether or not the skeletal dysplasia is present, and then do we think it's a lethal or non-lethal dysplasia. So we want to do a systematic survey of the bones, looking for the severity and the type of shortening. What bones are shortened? Are all the bones shortened, or just a segment? Are both lower extremities and upper extremities involved, or just one segment of the legs? Looking at the morphology and then the mineralization of the bones, and then are there any fractures present? We look at the chest, looking at a thoracic abdominal circumference ratio, looking at the face to see if there's any abnormalities to the shape of the head, looking at the spine, looking for platyspondyla, looking for increased spacing between the vertebral bodies. When the space is greater than the width of the vertebral body, then that's abnormal. We'll go over that. And then polyhydramnios. A lot of these babies end up with polyhydramnios. And then what is the gestational age? I mean, if we see short femurs and humerus at the 5th to 10th percentile at 32 weeks, and moms, 4'10", we're not going to be as concerned as we see this at 22 weeks. We just need to make sure we're using the proper vocabulary, so I'm just going to go over the different types of shortening. So the rhizomelia is when the proximal bone is shortened. Mesomelia is when the middle segment of the bone is shortened. Acromelia would be like when the hands or feet are smaller, the distal end. And then micromelia is when all the bones in the extremity are small. I've just got everything listed here for you so you can see the different types of dysplasia that are affected with the rhizomelic. So rhizomelic would be the achondroplasia, thanatophoric, the dystrophic. The mesomelic is going to be the Ehlers van Cleveland. And then the micromelia, achondrogenesis. I always remember achondroplasia is usually the type of dwarfism that you see walking around that do well. And the achondrogenesis or genocide, those are the ones that are usually the lethal ones. So these do fairly well, these do not. And then the OI, the osteogenesis imperfecta, type 2, again, those are with the micromelia and the short rib polydactyly. There's a whole list of them here for you. So skeletal dysplasia, the femur length and the foot length are roughly comparable in the normal fetus from 14 to 40 weeks. The femur-foot ratio, you're going to take it. The mean value is 0.99 plus or minus 0.06 either way. But if that ratio is below 0.87, that's abnormal. You don't have to measure the foot on every child. We do in our setting, but that's what we do. But if you suspect a skeletal abnormality, this is one of the things you can do. So is the femur short, or is the gestational age just off? Well, let's go ahead and do all of our biometry and then compare that femur to foot ratio. So your thanatophoric dysplasia, you have rhizomelia. And so you get this tissue redundancy because the tissues and the muscles are growing at the normal rate, but then you've got a short long bone. So you almost get like a little bunching of the skin and the muscles because you have all this tissue redundancy because that bone is not straightening out the tissues like it should. So the mesomelia, again, when we're looking at any of these skeletal dysplasias, start looking for polydactyly. A lot of these can be preaxial polydactyly, and then these are the babies when they're born. Bone morphology again, the shape, is it bowed? Does it look like a little telephone receiver? What is the mineralization? Do I have a good shadowing behind it? Or look at the skull. Does anybody think that skull looks normal? Look how hypomineralized that is. Are there any fractures that I can see? And with fractures, then you tend to get a little beading in the bone, especially like on the ribs where it's a healed fracture. The normal chest circumference should be 80 to 100% of the abdominal circumference. So you're actually going to do a thoracic abdominal, so get your chest circumference divided by the abdominal circumference, and it should be at least 80% of what that abdominal circumference was. In lethal dysplasias, the chest circumference is often only half the size of the abdominal circumference. And that's why you get that bell-shaped. It's pulled in where the chest area and then goes to normal size when it gets down to the abdomen. So you have a narrow chest and a protuberant abdomen appears bell-shaped on that coronal view. Again, that coronal view really helps us assess both of those. Because if you do just a transverse of the chest and a transverse of the abdomen, really not getting the correlation of that. You look at the numbers, but it's much more impressive when you do that coronal view so you can see the size of the chest to the abdomen. So pulmonary hypoplasia, again, is usually the cause of death. And then in OI, osteogenesis imperfecta, and achondrogenesis, you can have rib fractures that are also present. So again, that small chest size to the abdomen. Look at this. Look at how small that chest is compared to the abdomen. So this ratio, the thoracic abdominal ratio, is the single most important predictor of lethality. Because again, what do they die from? The pulmonary hypoplasia, because that chest is so small. Those little lung airways are never allowed to develop properly. It's just like when you have prolonged early oligohydramnios. If it's from a kidney abnormality, it's not the kidney abnormality they die from, it's the pulmonary hypoplasia. So you can get a cloverleaf skull that goes along with your thanatophoric dysplasia or homozygous achondroplasia. The hypomineralization would be a hypophosphatasia. And these are pretty impressive if you've ever seen them, because when you go to do your BPD, if you press too hard, you can compress the whole skull. And you're like, oh my God, I can see the intracranial structure so well. Well, because you don't have the normal attenuation to your ultrasound beam because there's not the normal calcification to the skull. It's pretty impressive once you've seen one. And then the microcrania with the frontal bossing and depressed nasal bridge goes along with the thanatophoric dysplasia, achondroplasia, achondrogenesis. So some of them overlap. So you start to look for what really is the hallmark sign for one of the dysplasias versus the others. So thanatophoric dysplasia usually has that really grossly abnormal clover leaf skull. The osteogenesis imperfecta and the hypophosphatasia, you can actually compress the skull. And then the hypomineralization, everything. I mean, look how you can hardly see any normal calcium in that baby that had the hypophosphatasia, but you can see them with some of your bad OIs too, with the osteogenesis imperfecta. Now the platyspondyla is when the disc interspace, so this space in between the vertebral bodies, is larger than the height of the vertebral bodies. So that's what you're looking at, because usually this is, the space in between should be smaller than what the height of the vertebral body is. So you start to look at that. And then we look for like the scapulas, because some of your abnormalities, like the camptomelic dysplasia, has a small scapula. So there's different things that you can look for to try to see, what category is it going to fall into. The skeletal dysplasias, the early onset and severe in many of the lethal forms, you're going to have the polyhydramnios, again, because just not moving things in and out of the lungs well. Third trimester onset of polyhydramnios can be mild to moderate in your non-lethal forms. So the earlier you see polyhydramnios, the greater the chance, and you see some of these other abnormalities, that it's going to be a lethal form. Because in your non-lethal forms, they tend to not get the polyhydramnios until later. So the four most common skeletal dysplasias that we'll look at, so the lethal ones is going to be the thanatophoric dysplasia, achondrogenesis or genocide, and then osteogenesis imperfecta type 2. Non-lethal are going to be your achondroplasia, the heterozygous, because the homozygous achondroplasia would go up into the lethal. And then the OI, osteogenesis imperfecta type 1, 3, and 4. So thanatophoric dysplasia, just like our little pie chart, shows us that that's the most common lethal skeletal dysplasia, about incidence of about almost 1 in 10,000. So thanatophoric is the Greek name for death-bearing. It's the prenatal genetic testing that we can look for is this FGFR3 gene. So they can take amniotic fluid, they can send it off for testing. So two types, type 1 and type 2. With the type 1, you have severe rhizomelia or micromelia. You can have the normal skull shape and macrocephaly, but you have those curved telephone receiver shaped bones. And probably you guys are too young, except for a couple of us, that remember what a regular telephone receiver looked like. It's not your cell phone. Yes. It's like, yeah. And usually there's no fractures and there's normal ossification. So it's the shape and the length of the bone that you're looking at. So for the chest, it's going to be a narrow chest, the short ribs, the protuberant abdomen. It's really, the abdomen's not protruding, it's a normal shape. It's actually that the chest is just so small. So, but again, gives you that bell-shaped appearance. So it's a narrow chest and then the normal size abdomen. The platyspondyla, again, looking at the disc space. Polyhydramnios, again, 75% by late second trimester. So severe with your lethal skeletal dysplasias. 50% of these occur, see, it's not always just mom. So 50% of these occur with advanced paternal age. So some of our craniofacial findings were the macrocrania, the frontal bossing, the depressed nasal bridge right here, and then the cloverleaf-shaped skull, and that'll be the type 2 that has the cloverleaf-shaped skull. And this is what those babies look like. So achondrogenesis is a lethal skeletal dysplasia, 1 in 40,000 births. Severe micromelia, so all of these long bones, they have hydrops. There's two types, type 1, type 2. Autosomal recessive in 20%. They have the hypomineralized spine and skull. They have the rib fractures. Type 2 is sporadic, about 80% of these will be type 2. Again, the hypomineralized spine only, but no rib fractures. So what do I see? What else can I find? Where else do I look? That's what you should be thinking as you're going through these. Achondrogenesis, the bone severe micromelia, redundant in soft tissue, and that can mimic, hydrops, and because of this tissue redundancy, because that bone isn't stretching out the arm, the tissues of the arm and legs the way that it should. You have an abnormal chest-abdomen ratio, a very narrow chest, distended abdomen, and again, rib fractures in type 1. The craniofacial, again, is going to be the frontal bossing, depressed nasal bone, but the hypomineralization of both the head, the skull, and the spine, and the polyhydramnios. But you can see these little rib fractures in here. And look at the spine. I mean, you can barely see the vertebral bodies there. Look at all the tissue redundancy. Look at the skull compared to the tissue redundancy. So OI is a genetic disorder of type 1 collagen production causing severe bone fragility, abnormal ossifications, and multiple fractures. So incidence about 0.4 per 10,000. Half of those, or 1% in 60,000, is lethal. So that's the type 2. So the type 1, 3, and 4 are different. They differ greatly in age of onset and severity of skeletal manifestations. Only type 2 and 3 are generally detected on prenatal ultrasound. So some of these you're not going to see on ultrasound. So the type 2 is uniformly lethal, severe bone shortening and angulation due to the multiple fractures. So you have the angulation, and then you get the little beading, the little bright areas where those fractures have actually started to heal. Again, demineralization of the skull, so you can compress it. The bell-shaped chest and the beaded ribs or wrinkled bones due to the multiple fractures and the healing of those fractures, and then limited fetal movements. I mean, look at this. You see that? Those are healed fractures. So that's when they call the beading of the ribs. And then looking at the chest. Okay, so type 3 is less severe than type 2. It's non-lethal, autosomal recessive and rare. You can have multiple fractures at birth. You can have scoliosis, short stature. And it's only detectable by prenatal ultrasound after about 19 to 22 weeks. So if you're doing an 18 to 20 week study, you may not see this. So your achondroplasia, or your heterozygous achondroplasia, is the most common non-lethal skeletal dysplasia. Incidence about 1 per 25,000 to 40,000. It's autosomal dominant, and 80% are new mutations. So it's lethal in the homozygous form. That means both parents are affected, and then you can have an offspring that's homozygous form, and then they can have a baby that has the lethal form of this. They usually have normal intellect and lifespan. The men get to a height of about 52 inches, and the women about 40 to 49. So they have a lot of orthopedic and orthodontic problems, and usually they'll do a C-section. Is recommended if the mom and baby is affected. So the bones, again, are going to be the rhizomelic, the proximal bones, that are going to be shortened. You have limb bowing, and it's progressive after 24 weeks. So, in your typical depressed nasal bridge with the protruding frontal part of the skull, a narrow foramen magnum, and upper C-spine may lead to mild hydrocephalus or spinal cord compression. So we do evaluate them after they're born for any ventriculomegaly. So with the spine, there's exaggerated lumbar lordosis. You can have polyhydramnios that has onset in the 3rd trimester. And then compare it to gestational age. What do you expect this time? And then looking at the gene mutation, it would be that FGFR3. So remember, lethal skeletal dysplasias, they are not subtle. We're looking at this, the femur, and the leg. This is that nice little profile that you like versus this. And you can see it just looks like there's too much tissue here for the length of that bone. So I know we went through those fairly quickly, but at least it gives you an overview of the main skeletal dysplasias, things that you should be looking for. But if you start looking at that femur-foot ratio and looking for when those long bones, when the humerus and the femur are less than the 1st percentile, measure all those long bones.